All right. Hello, everybody, and welcome to Functional Fascia Therapeutics, FFT, and the Fascial Sciences. I'm excited to be here with you all today. Just a little bit of troubleshooting to begin. If there's any issues with audio or video, just log out, log back in. It should work. So just try that out. If you have difficulty with the sound, just log out, log back in. Also check your sound settings just in case your volume's not synced up. All right, so before we begin, just to let you know, we are going to be having another live chat session with MyoPain instructors coming up. Just keep an eye on the MyoPain website for more information. I've been very much enjoying so far looking at all the other presenters. A lot of information here, really exciting. And please check out the upcoming sessions. We have Stu Wild at the end of the month talking on manual trigger point therapy. And then in June, we're going to be getting into men's health, pelvic pain, and pelvic floor dysfunction. And then at the end of June, whiplash and bruxism. And then July, a talk on tinnitus. So check those out. Really great information here. MyoPain Seminars is raising money for a great cause, the No Kid Hungry campaign. Any contribution, no matter how small, is appreciated. So I'm Ryan Shepard, and I am looking forward to talking with you all about fascia. So the overview for today, we're going to be, I'll just give you a little demonstration, a video on FSN, just letting you guys see it in action. And then I'm going to go into the fascial sciences, looking at function of fascia, the components of the fascia, and then going into the dysfunction, and finally tying it all in together with treatment and application of FFT in the system. So FSN is a fascial needle. It abstains 100% from the muscle. And it's an innovative therapy specifically designed for the treatment of myofascial pain and muscle dysfunction. The way it works, this is the most important point that we're going to be looking at here. So FSN reformats the fascial matrix. So FSN can really quickly and dramatically reduce pain. It's quite effective, and you can see drastic changes within really seconds of needle manipulation, which is pretty fascinating when we can see objective changes such as treating an anterior pelvic tilt. You can actually test before and after, and you can see a shift in the structure actually within less than a minute. You can actually see changes. So FSN was developed by, invented by Dr. Zhonghua Fu in '96, and based on the research and findings of Janet Travell. And it's currently practiced across Asia, Europe, and then I brought it here to North America. We just got FDA approval a couple of years ago, so it's been very exciting getting off the ground here in North America. It is a 23 gauge needle, a lot larger than your typical dry needle. So it's going to be having, because it doesn't go into the muscle, we're not going to be seeing too much discomfort with this therapy. However, it still is a needle, and just like any other needling therapies, there's still going to be, it's still going to possibly trigger some pain, but it's less likely. So we published our first paper in 2014 in English, actually. So this is our first English introduction for FSN, and that was pretty exciting. And you can see in the center there, the trigger point and the needles pointing towards it in that circle. That was really the foundation for FSN, and still used today in Asia and its teaching to go towards the area of dysfunction. And I've kind of taken from a few people in the field of myofascial pain, a lot of these experts, and formed the system of FFT, looking at a more systematic base and approach to treat myofascial pain and muscle dysfunction, rather than, it's still incorporating the palpation skills, but it's going a little bit further into creating a system and how from assessment to treatment and how to use this therapy. And one of the key points to using this therapy, because it abstains from the muscle, is that we can do active motion with the treatment. So during treatment, you can actually do contract, relax, ART, and with very minimal discomfort for the most part, because it's fascial. It's in the subcutaneous layer, so the muscle can still glide freely without having a needle there to impinge. And it alters the state of fascia and dysfunction, affecting not just the fascia, but underlying tissues as well. So muscles still going to be, even deep muscles like the psoas, the QL, the longus colli, can all be uh, uh, changed using just a fascial insertion of this needle. And we're going to get into this and how it works, but the flashlight effect, using a distal insertion to treat an area farther away, an area dysfunction, it's using this term that's been coined by Dr. Fu called the flashlight effect. And that is looking at, as the light goes farther out, it actually disperses. And so it can treat a wider area, of course, with lesser efficacy, but it can still have dramatic shifts in an area farther away. And then after reassessing and reevaluating, we can actually go more local. So I just want to show you a quick video here on FSN, and so you can actually see it live in treatment. Hello, my name is Ryan Shepard, and I was introduced to Dr. Fu in 2011 while living in the south of China. I trained under Dr. Fu and became certified in using FSN in 2012, where my career path was forever changed thanks to this new modernized medical device. FSN, or Fu subcutaneous needling, was invented in 1996 as an innovative therapy for the treatment of myofascial pain and muscle dysfunction. Fu has a double meaning, primarily as it is the last name of the inventor, Dr. Fu, but also has a meaning of floating due to the way the needle is inserted and manipulated. FSN is deemed extremely safe as it is limited to the subcutaneous layer, which is the layer between the dermis, the skin, and the muscle. This layer can also be referred to as the superficial fascia, where free nerve endings are few and collagen fibers are most abundant. Due to the lack of nerve innervation, FSN has been shown to be less painful as compared to other needling therapies. Due to its parallel insertion, interaction with more collagen fibers, and method of manipulation, FSN may elicit a greater clinical effect by means of mechanotransduction, a mechanical stimuli eliciting an electrochemical response. This mechanism of action produces palpable changes to tight muscles, even when inserting the FSN needle far away from the area of dysfunction. Dr. Fu has coined the term the flashlight effect as being the further away the area of insertion, the wider the affected area. FSN is a dry needle, meaning analgesic solutions are not injected. Rather, pain is treated at the source through the positive effects on the muscle. FSN has become very well known across many Asian countries, Western Europe, Canada, and the US, and continues to grow to allow many people around the world to receive a better quality of life pain-free. All right, so there you can see just a little bit of how FSN actually works and how it's inserted and manipulated, and you can see a little bit about the flashlight effect. So let's get into fascia and what it is. So there's a lot of definitions on fascia over the past few years. That's because it's not really defined by one definition. So there's been many interpretations over the years. However, we know that what we can take away from it is it's three-dimensional. And it's not just one layer that lies over the muscle. It actually penetrates all aspects of muscle, right down into the endomysium. And it really has been, the research is really great, but all we know right now for sure as fact is that it's a force transmitter. And I believe it's undervalued in treatment. So it's made up of mainly collagen fibers. Those are your most abundant protein in the body, as well as elastin and reticulin fibers. And it's all covered in a ground substance. So that's the ECM, that's your lubricators of the fascia. And it has an active role in tissue maintenance and repair. It's your soft skeleton, so it's necessary for stability. To ensure proper function, it's important that we have correct status, including orientation and organization of the fascia. And it's really prone and vulnerable to overuse, injuries, and strain. Loading on the muscle, for example, or repetitive motion, it can cause fascial restrictions. And we're going to get into that a little bit more. So we have a couple layers of fascia. We have three main ones, which is the superficial fascia, deep fascia, and muscular fascia. However, we're going to be talking mostly on the superficial fascia because that's really how the needle is influencing the body and the structure. It's by inserting into the subcutaneous layer in that superficial fascia. So it's not inserted into the deep fascia or the muscle. Now, the superficial fascia alone is made up of several layers, as we talked about. It's not just one sheet. And mainly it's the collagen fibers that we're going to be influencing. And it's very rich in water, and that's due to the glycosaminoglycans and your fibroblasts, which we're also going to be talking about, which are your main water regulators in the fascia. A dissection of 6 cadavers showed that the superficial fascia actually was found consistently in all dissected regions of the body, and not just superficial, but actually went deep. And so you can see its effect on the rest of the body is not just it's not just because we're influencing the superficial fascia. That's actually connected deeper down into the entire body is going to be affected. And here you can see the superficial fascia on an ultrasound, an MRI, and then dissected in the cadaver here. And it sits just underneath that fatty tissue layer. Thomas Myers came up with a great analogy looking at a grapefruit, and if we take out all the juice, we can actually reconstruct it, and we can actually see the structure of the grapefruit still. And that's pretty similar to looking at the top picture here, where we have a cross-section of the thigh, and the bottom picture with the muscle removed. That's just all the fascia that's left. And you can see that that skeleton is still there, that soft skeleton. And we can actually see how much of the fascia, it's not just superficial, but it actually goes right through the muscle. So, like I said, force transmission is what we know about fascia at the moment. There's a lot of interesting theories. There's a lot of research coming out, and it's awesome to be able to explore how the fascia really relates to myofascial pain and its involvement in the pathophysiology and development of myofascial pain and muscle dysfunction. But what we know is it is a force transmission system. And you can see here that 30 to 40% of the force generated by muscle is transmitted by the fascia. And that's quite a large percentage. You can see the gazelle, how it has these thin little legs. It can jump so high in the air due to the springiness of that fascia and the loading force. So collagen, the most abundant protein and the most makeup of the fascia, and we also have elastin fibers. Fibroblasts create collagen and elastin. They're the creators, and they help, like I said, the gatekeepers. They help to regulate fluid pressure. We're going to get into how fibroblasts are important when it coming to when talking on fascia and its mechanism of action for the development of pain. So here you can see as well another picture of the fascia, and you can see all the components, the different fibers, the fibroblasts. Now, fibroblasts help to control and modulate the extracellular matrix. So that determines the function of the system. And the viscoelastic behavior of the connective tissue is generally attributed to the material properties of the ECM rather than the cellular activity. So we know that fibroblasts within the areolar connective tissue, which is the superficial fascia. That's its most abundant protein, is areolar connective tissue. And these collagen fibers exhibit dynamic cytoskeletal remodeling within minutes in response to tissue stretch. So that's pretty huge, that within minutes we can actually see changes. And we can look at the structure of the fascia really like the hard substances such as the collagen fibers being surrounded by the ECM or the GAGs, which are your lubricators, or hyaluronin. GAGs are pretty much just long chains of hyaluronic acid, and that's your lubricator within the fascia. So glycosaminoglycans are water lovers. They're negatively charged, so they actually attract water, and that's how they respond to changes in the tissue. So movement of water in or out of the tissue is the mechanism by which fibroblasts sense a change in osmotic pressure and adjust their size to control fluid movement. So they can actually stretch, and we're going to see how that's important. So when fibroblasts undergo strain, it's a mechanical strain, the water inside is expelled towards the ECM. And if the hyaluronic acid assumes a more packed conformation, the loose connective tissue inside the fascia alters its density. So it's really cool to see this, because we're going to look at how the stretch of these fibroblasts actually, they create collagen by stretching. This is the basis, or supposedly by the Stekos, they've predicted that it may be the basis for the common phenomenon, myofascial pain, by the hyaluronic acid assuming a more packed conformation. And we can look at the fascia in its ability to really, we're looking at over or under hydration, and you think about the fascia like a glove over the muscle, and the tighter that glove fits, or the more dehydrated the fascia is or compressed, it's difficult to move your fingers underneath. So you can see how its relation with the muscle is apparent there in that description, that when the fascia becomes tight and restricting, the muscle underneath cannot move freely. Now, Gil Hadley, I'm not going to show you this video, but he's done a great job to explain the fuzz that builds up within the fascia when it's compressed. And these layers of fascia, when we have a lack of hydration or lubrication in the fascia, it's actually creating, over time, worsening of the condition. So the less you move, the more compact that fascia becomes, and the more difficult it is to actually release that glue, if you will, or the tight packed formation of the fascial layers. They kind of become stuck, and chronically. So if you ever get a chance to check out Gil Hadley, he does a great cadaver video through dissection and explains that fuzz, as he calls it. He's quite an eccentric guy, really great to listen to. Now, fascia and dysfunction, we're looking at the mechanosensory capacity of myofascial tissue, and increasingly implicated in many painful conditions. So we see it, the fascial involvement in chronic neck, back pain. We see it in frozen shoulder and nerve entrapment syndromes as well. Look at Dupuytren's contractures, frozen shoulder. There's a lot of myofascial involvement, and we can actually look at treating the superficial fascia to relieve a lot of these conditions. And we also see high levels of myofibroblast proliferation in the tissues, such as Dupuytren's. So myofibroblasts have been converted from fibroblasts in the muscle to myofibroblasts, where they actually have actin filaments, so they can actually contract just like muscle tissue would. And this is both in response to inflammatory conditions and also pathological states. And we can see fascial dysfunction from a chronic to an acute condition as well. So slowly evolving, such as disuse, overuse or misuse to an acute injury such as abuse, where you have inflammation, scarring, and fibrosis. Now you can see here in the upper left corner the disorganized collagen, and in the bottom right corner the normal collagen alignment. So you can see how it's nice and smooth on the bottom corner there, and on the top left you can see it's quite disorganized, and the collagen fibers are not smooth and in line. Now, going further into that tissue densification, we can actually see that the fascia and the hydration status is affected by tissue pH. We know that trigger points develop with a low pH. We have temperature and then tissue loading as well. So Stekos they published another study looking at the dysfunction of fascia and correlating it with an alteration of the loose connective tissue. So that's looking at the glycosaminoglycans and hyaluronic acid, and the alteration can involve one or all three components. Now, on the left here, you can actually see with no low back pain, you can actually see the glide of all the tissues independently compared in contrast to the right picture here with lower back pain. You can see the densification of, you can see the densification of the tissue here where it's actually not moving freely. It looks like it's just one piece moving all together, and these layers of fascia are compressed. And as I stated, the myofibroblasts, they cause that contraction of the fascia, and we're going to see that they are most abundant in the lumbar fascia itself. So fascial contractions, transition of fibroblasts to myofibroblasts within the fascia. And you can see here on the right how it's differentiated, and that's due to mechanical tension. So a couple of examples here where we have myofibroblasts development, which is Dupuytren's contractures and frozen shoulders. So all fascial layers contain a certain amount of fibroblasts with the ability to contract. So these myofibroblasts, they contain actin, and very similar to what you'd find in the muscle. And you can see here the high density of myofibroblasts within the lumbar fascia. They are most abundant there, and in relation to the entire body, you'll find them mostly in the lumbar region. So a lot of people that complain of lower back pain, this becomes something suspect to investigate, and not just looking at the muscle involvement, for example. So fascia may be our missing link to our understanding of a lot of these painful conditions. So fibromyalgia, or even myofascial trigger point development, they do intertwine there. And the inflammation of the fascia is similar to that that we find in plantar fasciitis and lateral epicondylitis. So it could be otherwise considered a dysfunctional healing response, and maybe it is more fascia than actually the muscle itself. And you can see on the right here of the deltoid, there is a discontinuation of that superficial fascia where there is scar tissue developing. Lower back pain, it may be that the fascia is primarily responsible, because one speculation is said to be that changes in the density of the fascial tissue, as opposed to pathology within the fascia, may be sufficient to entrap nociceptive nerve endings and cause pain. So nerve growth factor, we're not going to get into too much, but that does play a role here in the increasing nociception. In contrast to the fibrotic changes or densification, they're thought to reflect a change in the properties of the loose connective tissue component, and that allows sliding of adjacent overlying fascial layers. So myofascial pain, we know the muscle dysfunction component, but we can't really separate that from fascial dysfunction. It's not one or the other. It would be considered both. Anytime we have fascial dysfunction, we will have muscle dysfunction, and vice versa. And muscles contain fewer collagen fibers than subcutaneous fascia, and that's how the subcutaneous needling can be so beneficial, because we're influencing these collagen fibers to the largest extent. They're most abundant subcu in that superficial fascia. So fascia rather than muscle has also been shown to be the main source of pain and delayed onset muscle soreness. And fascia is the most pain-sensitive tissue in the lower back, even more so than underlying erectors. That was one study done in 2014. So it has been suggested that resting muscle tone may be significantly influenced by changes in the fascial stiffness, and sympathetic activation increases cytokine expression in the body. So here we are again with the myofibroblast contraction and increasing in fascial stiffness. Nerve growth factor, like I mentioned just slightly, has been shown to play a key role in the generation of pain and hyperalgesia. So it's expressed at high levels in damaged or inflamed tissue and facilitates pain transmission by nociceptive neurons. So the evidence is still coming along with nerve growth factor. We're not really to a point where we can conclude any findings, but it definitely gives us really good insight into what could be possible. There's a lot of great research papers that are up and coming, and it's starting to be more talked about, nerve growth factor, and it's how it plays a role in pain. One human study demonstrated that a single dose of nerve growth factor induced stronger mechanical hyperalgesia in fascia than in muscle. So although the magnitude and duration of nerve growth factor induced sensitization did not reach that previously reported for skin, thoracolumbar fascia was found to be even more sensitive. So we can see that lower back pain may have a different mechanism of action for its development of the pain. And there's important clinical implications suggesting that sensitization of the fascia rather than muscle by nerve growth factor is an important mechanism to consider for the contribution of and the pathophysiology of musculoskeletal pain. So here we can see, comparing these myofascial trigger points and their referral patterns to the fascial lines, and looking primarily at the fascia, we can actually see a huge overlap here, and it's very similar in the referral pattern. And the way we can influence these trigger points is through distal insertion along these same planes. And again, you can see here in the brachioradialis muscle here, you can see the referral as well. Very similar to that fascial line. Here we have a supraspinatus trigger point referral and the deep back arm line on the left, showing a very similar pattern again, how we can influence that that area is through insertion possibly into that tricep to influence that whole deep back arm line and look at that shoulder pain. You're all familiar probably with the Riger complex, but muscle release techniques which work exclusively on the reflexes or only directed at the treatment of Riger complexes, it's been shown to insufficiently affect the fascial aspect. It's impossible that it doesn't because you are needling through the superficial fascia, but it's not directly having a great deal of effect on the fascia itself. So that's where Fuß subcutaneous needling comes in as a very specific way to address the fascia. And there's obviously manual ways to do it as well. The Stekos have designed a program for that, but this is using a needle specifically addressing the fascia to treat dysfunction. And it does this through mechanotransduction. So mechanotransduction, looking at a mechanical stimuli converting into an electrochemical response. And mechanotransduction entails significant cellular change that occurs in response to biomechanical tension and compression. So cells can actually detect and react to the extracellular environment and adapt as necessary, which is really cool to look at. Now, you can see here the FSN video in the subcutaneous layer. Now, this is important to consider because we're stretching, we're not tearing, but we're stretching out that the superficial fascia, and it's stretching the fibroblasts. And what we know is when we stretch the fibroblasts, we're helping to realign them, one, but two, we're also helping for the fibroblasts to create collagen. And we can see that the dynamic ability of the fibroblasts and its ability uh, to change depending on the environment. We can see it within seconds, its ability to change. So if we can influence the fascia directly with a needle, a fascial needle, and stretch those fibroblasts and pull on those collagen fibers, we can have really a huge clinical and immediate clinical effect. So we can see improved range of motion, decrease in pain, and within a short period of time, just due to how the needle is inserted and manipulated. So that brings us into just the ability to go from a muscle-specific view to the big picture. And when we're talking about the big picture, we're looking at something called the tensegrity model, Fuller's model. And key points here that we're looking at are elasticity, deformability, mechanical transmission, and restoration of the form. But we can take that one step further. Tensegrity is a little bit of an older model, and we can actually apply it now, biotensegrity, and we're going to get into that a little bit about how it applies more to the human body than, I guess, structure, like building structure. So according to the concept of tensegrity, the organization conceived of the structure allows restoring to the original form, and we can actually see without damaging the components that constitute the tensegrative form. The key concepts to the tensegrative model are elasticity, deformability, mechanical transmission, and restoration of the form. So biotensegrity is more complex because it really looks at its application to the human body and looking at how it incorporates the fascial system being a whole one network, three-dimensional network that goes head to toe, and we can influence this whole system by addressing one specific area, or many areas, but one area that we're needling to address an area farther away. Fascia integrity has been, it was just last year actually, in 2019, there was a paper that came out just talking about biotensegrity versus fascia integrity and looking at this new term that they're kind of coining to show how it kind of relates to the human body more than maybe the tensegrity model does. So that was a good starting point, and it's just expanded beyond that. So the cell is immersed in an environment of constant information, which we know, and stimulates and determines the cellular behavior based on the environment. So cellular survival depends on the ability to warn such information, and mechanical information comes from the tension of the extracellular matrix and from stretching and shear stress on the liquids. So deformation of the cell, of the cellular form, in front of this information is the language that the cells use with respect to its mechanometabolic environment. So we can see how we can influence this fascia. Interstitial fluids can create tangential drag or wave forces influencing the composition of the same matrix or the alignment of the collagen and the behavior, remodeling the cell. How does that tie into the application for FSN? We need to start with a fascial assessment, going from that big picture, looking at that tensegrity model, the biotensegrity model, the fascia integrity model. We have to look at fascial assessment as a big picture. And because all these planes are connected, we have antagonists. We're going to get into these planes a little bit, but it really just starts with a postural assessment. And there's key areas to really look at and how we can influence the structure, looking at the foot and the ankle, looking at if there's pronation, supination. We can look at the pelvis and see if there's an anterior pelvic tilt, posterior rotation, or if we have an upslip, and we have to look at the neck as well. So following that main chain, we can influence, in my opinion, best by working with the pelvis. I really do believe that stability really all starts in that pelvis, and if we can help to regain that structural alignment by influencing the dynamic of that pelvis, if we correct that anterior pelvic tilt or that upslip, for example, we can really influence a lot of places in the body distally. So for example, TMJD, a lot of people with jaw dysfunction, we can actually look at that deep front line, which we'll get into, which is the central line, your core, and see how we can influence the body and just by treating that pelvis again. So we have 12 fascial lines, and this is going along with Thomas Myers. They are distinct and coherent dissectable lines of myofascial connections. So unlike meridians, we can actually see them as a whole. When we dissect, we can actually see these planes. They're visible, and the connections that they establish around the body are actually quite amazing to be able to see. And so influencing the fascia from one area to affect another, it's pretty awesome. Each myofascial plane has a function beyond the function of each individual muscle within it. So you were looking at the fascia as a whole. So instead of looking muscle specific, for example, we have that front functional line, looking at that shoulder to throw that football. It's the function, it's not just coming from the shoulder joint itself, but it's actually coming from the contralateral adductors as well, looking at that front functional line, the force transmission, and to be able to throw that football. So we're looking at these planes as a whole and not just muscle specific. So if we relieve strain in one area of the body, we can export some of, of that load to the other parts of the body up or down the line. And like I was saying, that deep front line, it's really the core. It's the most important one to look at in your structure and stability. So that's always the go-to for most complaints. And you can just see everything caves forward. It caves inwards. We have an anterior rotation of the pelvis. Our diaphragm just draws our head and neck forward. So we can see a lot of tightness there. And that would be the main point to influence the whole structure. So I look at people with foot pain. I look at people with lower back pain or all back pain. It is related to that pelvis and where it sits in its plane. So we have to look at the antagonistic fascial lines as well. So looking at the lateral line in contrast to the deep front line, those two antagonize each other. You can see the third picture in would be that lateral line, and it actually antagonizes that deep front line. So we can see, think about a bow and arrow analogy where we have pronation or supination. If we have supination, we're actually seeing a lot more tightness and pull in the deep front line. And you can imagine putting a string on the inside of the foot and going all the way to from the center of the body all the way up to the head, and then you have the same thing coming on the outside of the foot, and you have a piece of string attaching there going all the way up the lateral side of the body. And if we have pull on one side, it's going to be influencing the other side. So if we have supination and we have tightness in that deep front line, we're going to be seeing a little bit of bow-legged. We're going to be seeing pull on that outside of the leg as well. In that bow and arrow analogy, you're thinking the tension's held in that deep front line, and then the body bows towards that pull, that force, that place of tension. So anytime we're seeing pronation or supination, I'm always looking with fascially speaking, I'm always looking at the either line, the deep front line involvement or the lateral line involvement. And that's always the place to start. And usually it syncs up with working on that pelvis as well. So anytime you see supination, I usually see along that is going to be an anterior pelvic tilt. So we have an upcoming certification course for FFT, the first one in September and then again in November. These are really, we just don't know what's going on right now, so they're set, but they may possibly be postponed depending on the current situation, the current climate. So we'll have to wait and see the updates, but as of now, we do have a couple of courses on the books scheduled. And I'd like to open up to questions now. We have a little bit of time to answer some questions. So we have a question, other than the needle difference and maybe location strategy and needle placement, how is this different than what Baldry described with superficial dry needling over trigger points? Well, the way that it's manipulated makes a big difference because it's really stretching out those fibroblasts and pulling out the collagen fibers and helping to realign them. So there is going to be a difference there in how it's inserted. So if you look, I'm going to use my arm as a demonstration here if you can see okay. If I go perpendicular, and I don't have to go into the muscle at this point, just like Baldry would do, you go just superficial, you're influencing some of these fibers and you're still going to have that mechanotransduction. You're still going to have that effect. However, if we go parallel to the skin and we're crossing several more of these collagen fibers, we can have a greater influence. So that's just one way that we can see its benefit there. So a visual scan to determine where to needle, it's really, yes, we are looking at the structure as the primary go-to. That's our primary insertion point, is looking at if we have an anterior pelvic tilt, we're going to be going from a certain placement, so more specifically in the anterior medial thigh to address the psoas pull, for example, but we're influencing the fascia. However, it would be the psoas that we're treating, which pulls that pelvis anteriorly. So it is going to be a visual scan, and you can use any kind of program to help determine which area, looking at taking pictures from the front view or the lateral view, side view, you can actually see which area is of most importance to treat. But looking at the feet, looking at the pelvis, looking at the shoulders, it's a really obvious placement to find where to treat, and then you go more specific after that. So once you really regain structural alignment, it highlights areas that really need more work maybe. And you can do that with a local insertion for FSN, or you can do that with other modalities. So this can be just a tool in your toolbox, and you can use your dry needles or other fascial manipulation methods. So we are scanning the body, and then depending on the area that's affected, we can do certain ROM tests to address. So common condition and how I treat it. Lower back pain, for example, is something that we're all going to see a lot of as pain specialists. So usually you treat it from correcting either, I always say the front's more important to look at than the back. And yes, you have to rule out a lot of your differentials and do your assessment appropriately. But just generally speaking, if somebody has back pain, I always address the front first. So usually it's the abdominals that are referring in, and I can do a fascial insertion into the abdominals as well. But correcting that anterior pelvic rotation is key, and I do see that clinically over and over. It's repeatable, the results that I get just by addressing that pelvis. So even an upslip, and you know that there's QL tightness, you can still address that from the front just by addressing that psoas pull or that anterior pelvic rotation. We can actually see a correction of that pelvic upslip as well. So scar tissue work, twisting motion. Yes, so we rotate the needle to hook on those collagen and elastin fibers around that needle tightly pulling. You can actually feel the tug. Scar tissue works a little bit different. You could do FSN. I have done it along scar tissue, but again, I'm not rotating it. I'm actually still manipulating along the body. So it's not twisting or rotating, it's actually moving it, sliding it back and forth, and it's tugging, stretching out those fibroblasts as we saw in that short video there. So how long does it take to achieve lasting effects? That's one question I get asked a lot by patients. How long do I need to come back? We're not going to see long-lasting changes after one treatment, of course, just like any modality that you do, depending on the factors affecting or contributing factors to their case, their condition. We're going to need them to come back a couple times and give them homework, prescribe stretches, and things to maintain what we did in that treatment. So usually it's twice a week for 3 weeks that I ask them to come back, and then we reassess once we see things are holding a little bit better. I've had cases where I've treated plantar fasciitis just by inserting the fascial needle into the gastrocsoleus complex. They haven't had to come back again. It was actually, they came back 5 months later, 4 or 5 months later. So one treatment was enough to hold them off for that. But that's only because their specific condition was due to the fascia in that superficial backline, as you call it. And if somebody had, more trigger point development in the heel, it can help. It can take off the strain, but you may need to go in there with, the quadratus plantae muscle, for example. You may need to needle that directly. So it can be a tool in your toolbox, or in certain cases, depending on the presentation, you can use it as a sole means for treatment. Share a bit more about the techniques used in functional fascial needling. I've done some around scar tissue and got great success, but never seen the other arm used with counterforce showing in your video. So the counterforce, that's a good point. It's actually important to, like I said at the beginning, because we're fascial and we're superficial, we can actually do contract, relax, and engage the muscle that we're working in, and it does improve the clinical efficacy of the therapy. So we can get a better effect. It's not necessary, however, it can achieve a greater clinical effect by resisting that muscle that we're working on. It increases the circulation, blood flow. So what professions can perform fluid subcutaneous needling? It is if you're licensed to do dry needling, if you're licensed to do acupuncture, if you're licensed, regardless of your profession, if you're licensed to insert a needle below the dermis, you can perform fluid subcutaneous needling. And for billing purposes, it would be billed. If you're a PT, it would be billed the same way as dry needling. So demonstrate how to insert the needle in the fascia. That's something that I did show in that video. If you check out the FF Therapeutics website, you can see that video again. You'll see how it's inserted into the fascia. It's using a insertion device, which helps to go in painlessly. It's just a spring-loaded applicator. And that would be more specifics within the course to find how to actually find the sub-Q and know that you're in it. Just know that you're not too superficial or too deep. Hemiplegia, I have had a couple cases. Minimal, but some improvement just with the fascial needling, but I've done more scalp needling. Okay, what do you feel so you know the needle is in the superficial fascia and not just in the fat layer? So again, that's going to be more specifics within the course to find how to know that you're in the subcutaneous. It's actually pretty easy to feel. but that's going to be more specifics when learning how to use this therapy. So the needle, how long does it stay in? That's a good question. Usually it stays in for until you really see change. It's about a minute or two. I've had change in less time than that. Again, looking at that anterior pelvic rotation, we can actually see a shift pretty objectively before and after. You can measure, and that happens within seconds. However, I would go a little bit longer just to influence that fascia a little bit more. Up to 2 minutes. It tends to get a little bit sore after if you're doing it longer than 2 minutes. Up to 2 minutes, it's not really an issue, but the longer it's in there, the more you're wiggling about in a body, it's going to become more sensitive or sore after a while. So it does depend on the area that you're treating. Sometimes you can get a very quick release and then reassess, reevaluate, move to another area, or it just may take 1 or 2 insertions. And usually you're not using more than 3 insertions in a treatment anyways. What other treatment options do you typically use, such as exercise? I will prescribe homework, such as exercises, not really strengthening exercises, but more stretches and looking at fascial applications as well. So dynamic stretches incorporating the whole body. Yoga, a lot of yoga poses tend to incorporate the whole body, functional movements. Is it possible to manipulate fascia by dry needle inserted in superficial fascia and rotated clockwise and anti-clockwise? What is advantage of FFT over fascial manipulation using dry needle? Again, I think I answered that in an earlier question. We're going across rather than in perpendicularly. So it's going to be influencing a lot more of these collagen fibers and having a greater effect due to that. You cannot do that manipulation. If that's the question, you cannot do that manipulation with a standard needle, whether acupuncture or dry needle, because that needle tip is a lot more sharp. This is a dulled needle tip. We specifically dulled this for our purposes. And you wouldn't be able to do that motion without causing, I guess, harm or pain. And the needle is also a lot thicker for that purpose, so it doesn't bend. It actually moves quite well and fluid within the fascia without bending. So you couldn't do that with a regular needle. Books explaining Fu's technique. Yes, they're in Chinese. I provide a manual within the course as a clinical guide, but the books currently are in Chinese, written by Dr. Fu, and not using the FFT method, where it's really looking at the fascia as a whole more so. It's very much directed at the area dysfunction using your palpation scales. I've just developed the system to take it a little bit further. That's a good question about the video I showed in the cadaver. Was it performed on an embalmed cadaver or an untreated cadaver? I'm not too sure about that, to be honest. I'd have to inquire with Dr. Fu about that. How many times do you manipulate the needle? 100 times in a minute is kind of a good estimate, depending on where you are, how long you're there. In your study, have you encountered any research for supplements that promote healthy fascia? Being a naturopath, I definitely recommend supplementation. That's going to be a whole different discussion, though. Look at Chapter 4, Perpetuating Factors, in the old Chevelle. That will give you your answers. Are you palpating fascia densification similar to stecco, where you choose where you place the needle? Palpation skills are key for this therapy. It's not just visual, it's not just looking at the structure. That's a key component to it. And I do believe once you regain structure and balance in that structure, you can actually treat a lot of conditions. And but it's a little bit different than the stecco approach. They have very specific areas that they go to, depending on the issue. So we do palpate. It is important to always see with your fingers, feel the area dysfunction for sure. So Can you please describe the size of the needle, the gauge, 23 gauge? How long do you manipulate the needle? I answered that one just 100 times in a minute, but it does vary. Always palpate, reassess, see the changes that are happening within that short time that you're in there. You'll be able to witness changes, palpate, of course, the tissue, and see if there's any change. If 2 minutes has passed and you haven't seen changes, then definitely reassess, reevaluate, find a different area to look at. There may be a better area to address that dysfunction, or you may not be at the root of it. So how similar is this technique to Graston and other instrument-assisted fascial techniques? Very different. So we're actually stretching the fascia, as you saw in that video, and we're not really, Graston would be more relatable to the physical modalities, the manual therapy, and fascial manipulation. So this is slightly different. Any contraindications? Good point. There are a few, but because it's a superficial needle, it does not go into the fascia, into the muscle. It stays within the fascia. The only contraindications are that external jugular, because that sits within the fascia, and then you have your pre-post auricular arteries and veins. So you'll be able to feel for those, that squishy bag of worms. But that's really the only contraindication. Even people on blood thinners, yeah, extra precaution. Hemostasis is obviously key, but it's not really contraindicated. So the paper that I reference says to leave the needle up to an hour. Well, actually, a little bit of a different topic we're not going to get into, but in China, they do needle retention, where they leave the soft tube casing of the needle in the dermis. They leave it in for a long period of time, which is not legal in North America. Can you learn the technique in one weekend? Absolutely yes. It is a 1 weekend course. It's a fairly simple therapy, to be honest. And what's most difficult for people who undertake the training is learning the manipulation technique, how to sway that needle back and forth. That's a little bit tricky. It's a new skill to learn, and everybody struggles in the first couple hours, gets the hang of it by the end of the first day. Second day, they're all pretty well efficient and pros. So the course is very hands-on, and by the end of the 1 weekend, they will be very effective. More bleeding due to large diameter needle? Not so much, unless you're hitting a nearby blood vessel. There shouldn't be any bleeding at all, but yes, due to the large diameter, you're right, it is possible that if you're going to bleed, it may bleed a lot more than your typical dry needle. But you can hit a superficial vein, a blood vessel. You can get some bleeding, or if you go obviously too deep, which you shouldn't, if you're in the deeper fascia or you go into the muscle, you'll get a hematoma, but that shouldn't happen because you should be abstaining from the deeper layers. But good question. Most of the time, if you're doing this appropriately, if you're a experienced practitioner with FSN, you shouldn't be seeing much bleeding at all. So retention of the FSN needle is usually necessary in order to avoid symptoms from recurring frequently, although they can be easily suppressed after therapy. Well, that's where the homework comes in. We can do a great job within the clinic, get them to a pretty good place of comfort. We can get that range of motion improved, and we definitely want to send them home with homework to do with stretches, because we can get the dysfunction, that muscle, from here to here, but we want it here. So when we release them, let's say the trigger point in the muscle, and when I'm talking trigger point because we're influencing the fascia to treat the trigger point within the muscle, if we do that, we're actually taking the muscle into a relaxed state and discharging that trigger point. but we want to make sure that now that's our golden opportunity to really influence the body further. So stretch, always important. So needle types, please tell me more about needle types. So I only teach on the one needle here because the one used anywhere else for FSN in Asia by Dr. Fu or in Europe, they're using the same needle, not as me, but the one that Dr. Fu supplies, it is for the purpose of needle retention. It's a little bit larger, but I teach only one type of needle, which is specifically for me. We designed it after trialing it in China. We decided to design a new needle for my market because we don't do needle retention and there's no need for that soft tube casing. Any area of the body you would avoid needling? Typically the palms, soles of the feet, and the face you definitely want to avoid. Anywhere else is accessible, even the scalp. So EDS patients, yes, it can help. I am not an EDS specialist, so I don't see all that many, but I have seen a few, and I have gotten good results. Would this be a good adjunct to vibration percussion therapy? Absolutely. You got those Ruffini receptors going. This is a great addition to percussion therapy for sure, because it's addressing that fascia a little bit differently. All right, so we got one more that popped up here, CRPS, complex regional pain syndrome. Yes, I have worked with it, and I have gotten some good improvements. Obviously not treated it, but I have gotten reduction in symptoms and pain. I haven't seen enough to really conclude any findings, but the patients that I have seen with CRPS, I have gotten some good results with. Most common regions for treatment. I'm always going to the pelvis. I'm biased. That's where it all starts for me for the most part. However, common regions for treatment, a lot of back, feet, and then neck pain. But even neck pain, even if it's posterior, you can treat it in the front. Looking at that deep front line, for example, pulling those shoulders inwards, creating strain in the back of the neck, you can definitely release that tension, increase range of motion. So addressing front lines, how do you deal with obese abdomens? That actually surprisingly comes up quite a bit in the courses in questioning its efficacy in larger individuals, and it's not an issue. You can still get great results, even inserting into the abdomen to treat lower back pain, not an issue at all. I haven't found any decreased efficacy when treating lower back pain due to abdominal trigger points and using a fascial insertion in the abdomen itself. It still works. Do you combine FSN with dry needling? Absolutely. I am a fan of dry needling. I find it definitely has its purpose, and in my practice, of course, for some, it's the only thing to use. For others, like myself, it's just another tool in my toolbox, and I'll definitely look at some other manual therapies. I'll do some traditional acupuncture, and I'll also do some dry needling in combination with FSN. However, I explain it like using FSN to peel the layers of the onion. You're starting with the superficial layer, just really addressing the structure. A lot of their symptoms will improve, and then it will really highlight the areas that still need to be worked, whether that's going to be a local insertion with FSN or using dry needling. I just worked on a gentleman the other day with shoulder dysfunction, and we got really great improvement, but just doing that ROM test before and after, I wasn't able to shift. That pec stayed tight. Even though there was less pain, the range of motion did not improve as much as I was hoping. So go in there with dry needling in that pec minor, and it was definitely very much improved by the end of it. So the two combined work really well. Some just use it because it's gentle, alone. It is gentle, so some people just use it on its own, but it can be used in combination with adrenaline, of course. All right, so I see there's no more questions here. Thank you all very much for attending. I appreciate the feedback and all the questions, and I'm happy you guys enjoyed the talk today. Thank you.